place that is called Toronto is still the home to many Indigenous people from across Turtle Island. I'm grateful that as an immigrant of African descent, I have the opportunity to live, to work, and thrive on this land, and to welcome all of you to participate in this dialogue with us this morning. So I would just recommend that you take a few seconds or moments to acknowledge the land that you are on, the lands that you come from, the lands for those joining us remotely that you are participating from. So hopefully you got a glimpse or a shadow of the solar eclipse yesterday from wherever you were. Thank you so much for joining us today. If you were here with us yesterday, it was a pleasure to have you. We're continuing the conversations around reimagining equitable and integrated support for newcomers and refugees to Canada. And I'm doing this on behalf of the entire project team. We're going to continue today acknowledging the fact that there are people whose contributions of funding, time, labor have made today possible. I'd like to acknowledge that we are being funded by the Social Sciences and Humanities Research Council of Canada, Quest AV, who has been our fantastic audiovisual support, Women's College Hospital that has provided the space and the facilities for us to hold this event, and the Dalalana School of Public Health, University of Toronto, who has equally contributed in kind to this event. So for those joining today for the first time, and those even who were here yesterday, I thought it would be helpful to go through a recap. Yesterday evening, I was seeping and just percolating on all the rich things that we heard and shared yesterday, not only as part of the panel, the keynote and the presentation, but also during lunch and side conversations, I was able to get insights from how people had, what they had heard and how it had landed for them. So yesterday was really starting with the keynote by Professor Anna, who demystified immigration and really set the tone for why this topic is important and why we need to take an equity, social justice, and critical approach to solving for it. Her talk invited us to question the narrative. You know, is our immigration policy, irrespective of the pathway, is it instrumental and should it be people-centered, where we really go back to the phrase that she shared of Canada invites people and not workers. I think in some ways, given how immigration has become a commercial goal, we seem to be moving towards prioritizing the work and the labor over the people. And we know that labor has very deep colonial roots. Another thing that came to the surface is that even though health is central to how people manifest their experiences of the social system, it's not necessarily foregrounded in their migration pathways, whether you're an asylum seeker, you're a government-assisted refugee, you're a privately sponsored refugee, you're an economic-sponsored temporary migrant, whatever pathway it is, health manifests the symptoms of our society, but is not foregrounded in how we approach immigration and integration. And so we were called to think through access to healthcare and who is prioritized when thinking through access. And the presentation that I shared for how we got to this tagline of needing to move beyond technology and beyond healthcare foregrounded the social determinants of health as being critical in how we look at the dynamics of who, how, when, and where access to healthcare happens and why we need to integrate health and social supports. Another thing that came through, you know, from the question session as well as side conversations is, so what do we do now? And I think that Anna put it very well in sort of structuring and ending her presentation with three possible solutions. We need to support integration of newcomers as people, but also integrations of systems and sectors that are supposed to provide the wraparound support and access. We need to facilitate transition so that people have hope as part of their migration journey, immediate, medium, and long-term hope that they can make a home and a future in Canada. And then we also need to change the narrative. And I remember that one of the questions was, well, there's so many moving pieces and these are complex issues. How do we change the narrative? And I think that that's what these dialogues are about, to think about what needs to be done where do we have in our individual spaces and in our spheres of influence, whether as academics, trainees, learners, researchers, policy actors, community activists, where is our sphere of interest, influence and control, and what do we need to do together about it, because it's such a huge problem, we cannot do it alone. I think there was also the other question that stayed with me, which is, not much of this is net new. So why does this remain an intractable problem? And that leads us to really reflect on the moral and ethical considerations of why is this an important topic and who should be working to deal with it. At the end of the day, we will need collaboration, we will need partnerships, we will need interdisciplinary and multi-component approach. So as we start today, I'm inviting everybody to think about why now, what now, and how me. So today's dialogue is going to be broken into two main parts. We're going to start with panel presentations. We're going to have 4 speakers who are going to speak to this complex problem from the lens of their lived experiences and their expertise. And then Professor Nancy Clark will have a facilitated discussion with the panelists, after which we will break for lunch. After lunch, we're going to have scholar presentations by 2 emerging scholars. And then we'll have a review of a visual capture of our thoughts and ideas that have been shared so far. And then we'll close. And there's a possibility we'll close early today, even though there's no solar eclipse. But I promise that we're going to keep to time. As a recap, meeting tips and guide, if you're in person here, here's the username and Wi-Fi access password. You can also see it on the wall in front of me here. Live streaming is being done, so hello everyone who's joining on Zoom. For those in person, there's beverages and snacks outside. Just walk out dead center. You'll see the table. Feel free to help yourself. If the coffee is too cold for you or the tea, there's a microwave around the corner near the cloakroom where you can warm your beverage. Break rooms and restrooms are around the corner to the right. Emergency exit is over here to my left. We recognize that there are people who are observing the month of Ramadan. If you need to take a break to go pray, there's a prayer room down in the lobby of Women's College Hospital. Just ask at the reception welcome desk or the security desk and they will direct you there. Please try to return your badges when you're leaving, even if you leave during the day, because we would like to repurpose this for the May events. So today we have a special guest. You will notice that there's a very elaborate setup in the corner. But I'll invite Brittany Dachko from Feels Like Creative to introduce herself and tell us what to expect as she engages with our conversation today.
Thanks. Hi, everyone. I'm Brittany Dachko, and yes, I'm going to be listening to your conversations today and taking the high-level themes of what you discuss, as well as what the panelists discuss, and I'm going to be capturing them live on that graphic over there. And I do have notepads as well at the front, like little stickies. So if you'd like to contribute any thoughts, you can write them on the stickies, and I'll be sure to look at them and make sure that they're captured on the board later on. So thank you so much for having me.
Thank you, Brittany. So feel free to make notes, take breaks. Like during breaks, you can go down, see how the visual is coming out. Pick a sticky, write a theme, a note, something that struck you. Write thank you notes to Brittany as well. I think that's always helpful. So thank you, Brittany, for joining us. So key personnel for today, obviously Brittany, myself, Priya is still with us today over here helping us take notes. Isabel is also in the room there, and Nancy, who's going to be our expert facilitator for the conversations. And now to begin, it is my pleasure to invite Professor Denise Spitzer, who is a professor at the School of Public Health, University of Alberta, and an adjunct professor at the Institute of Feminist and Gender Studies, University of Ottawa. From 2005 to 2015, she was the Canada Research Chair in Gender, Migration, and Health, and a principal scientist in the Institute of Population Health. She has been engaged in participatory research with migrant communities around the world, and Dr. Spitzer is interested in examining how global processes mediated through intersectionality are implicated in health and well-being. And her talk this morning is titled Intersectionality and Migrant Health, the Need for Structural Inquiry. Welcome, Denise.
Thanks.
Thank you very much. And while I am getting set up here with my paraphernalia and the correct reading glasses, and which is obviously my water will not go anywhere, so I'll just put that here. There you go. I just really want to thank the organizers for inviting me here today, and also for really doing an excellent job of organizing this session. So I hope the folks online are also recognizing how much work it is to put all of this together, and you have been really masterful. So congratulations to all of you for everything that you've been doing. So, okay. Let me put my glasses on so I can see what I'm doing. Ha ha. And thank you also for the great introduction. So let's hope I know how to operate. Do I use the mouse? Oh, the clicker. Which one? This? Green. Okay, good. I understand colors. Green button. Okay, I can do that. We started yesterday in today's session with a very beautiful land acknowledgement, but I also want to add a bit of my own. I'm a migrant settler. I reside on stolen, unceded Algonquin territory in a place called Ottawa, but I work on Treaty 6 land in northern Alberta. And I like to use these moments of land acknowledgement to not only have us reflect on the harms that have been done and continue to be done to Indigenous peoples on Turtle Island, but also across the world, but also to follow in my own tradition of Tikkun Olam, of healing the world, as a way to commit and recommit myself to being an accomplice in unsettling these ongoing wrongs, and to joining others in struggle for social justice throughout the world. And I hope you will, again, reflect on what these mean for you as well. Okay. Next slide. So we've been talking about intersectionality and using the term for the last day and a half a bit, and obviously longer in your own work. But I'd like to take a moment for us to unpack it a bit. So in essence, intersectionality allows us to examine how social beings are situated in and presented to the world as whole entities, where we are located as well then in social, political, and economic hierarchies. So coined by Kimberly Crenshaw in 1989, intersectionality is also grounded in Black feminist scholarship and activist struggles since the 19th century. And I think it's always important that we acknowledge those contributions, because that's where these ideas are really rooted. Intersectionality is simultaneously, for me at least, a method. It's an analytical lens, but importantly, it's also a tool for political action. And it was always meant to be that. And we sometimes, I think, in the ways in which that term has become co-opted by many institutions and organizations these days, that we have to, keep that that notion alive in our engagements with the concept. And of course, it has changed over the last 35 years. And I tend to think of intersectionality as the shifting constellation of mutually constituted markers of social differentiation. So these are not rigid, additive axes of differentiation, but really things that are interpenetrating issues such as gender, ethnicity, racialized, socioeconomic, sexual minority status, disability, indigeneity, age, geography, amongst a variety of other ways in which we differentiate peoples. And it's really taken together that as whole entities, where people are exposed as individuals or as groups of individuals to both deprecations of power, but also as giving people access to certain privileges. So I regard intersectionality as the sinew connecting identity, social structure, and the materiality of social location. While often our attentions and efforts are drawn to mitigating the outcomes of structural inequities and that are bound by our notions of intersectionality. I think it's really important that we consider it intersectionality at the same time, retaining focus on the power relations that underpin the architecture of those social landscapes. So it's imperative to interrogate not only how intersectional status is historically and sociopolitically constituted and embedded in structures, but also why they are and who it is benefits from these kinds of inequalities, because these are not natural, right? There's a reason why certain kinds of bodies are constructed in certain kinds of ways. If that's not complicated enough, because we mentioned complications yesterday, and I'm just going to complicate things further for you. Intersectionality is, living intersectionality demands that we think about the ways in which it is also very fluid. We inhabit disparate and sometimes overlapping social locations throughout our lifetimes as we age, as we become, some of us, disabled. Even over the course of a day, as one transits from one place to another through different spaces and places. Mobility, and of course, for migrants, mobility, crossing borders, involves moving through and into different kinds of social landscapes. You're positioned in different hierarchies in different contexts. And it's really, we need to be thinking about how sort of shifts in social positioning affect how people are experience their intersectional status and how they are situated within those various landscapes. And it's really, we have to also think about the dynamics of these shifting positions and what that means for people. So really, intersectionality is composed and rematerialized in different locations, even though some of the harms that are inflicted by a certain social position and a certain social exclusion can persist. And I'll give you some an example later that I hope will kind of illustrate what I mean by that. But even if we think about how many migrants to not only Canada, but other immigrant receiving countries like Australia, the UK, and the US experience downward socioeconomic mobility, and again, predominantly racialized women, many of whom are, as Anna said yesterday, very highly educated, we see that, in fact, that downward mobility mimics and is not unsurprisingly, I think, correlated to what we see as who are the people that are most apt to lose their healthy status, right? So when we used to, early days, look at the sort of general population-based data about the loss of the healthy immigrant effect, and we actually started to pull out sort of sex disaggregated data and realized, in fact, it was not a uniform process, but in fact it is racialized women who have the most precipitous decline in their health status, and again, they're the ones who actually have also the most precipitous decline in their socioeconomic status as well. Moreover, of course, as we know, gender roles and ideologies shift with migration, which require recalibration, and sometimes that can be very challenging. And we also, people experience racialization, where often race labels are imposed upon people and position them in ways that they hadn't been previously accustomed. So I always joke that something really weird happens at 35,000 feet. So if you fly like from Argentina and you're Argentine and you see yourself as a European Argentine and you land in Miami and suddenly, whoa, presto changeo, you're Hispanic. How did that happen, right? And so, and also when you come from a place where you are part of a majority culture where everyone in all walks of life looks like you, shares your same religion, and then you move to Canada and suddenly you're minoritized and your religion is denigrated or suspect, right? That these are really dramatic shifts in how, in its self-identity, but also in the way people are positioned within society. And sometimes people don't have the tools to understand what is happening. And so it takes time to adjust if you've, to learning how to mitigate or to combat some of those forces of oppression that you never really had to deal with at home. On the other hand, sometimes having those kind of jarring experiences, people also can be positioned in a place where they can develop solidarity across understanding who else is being sort of positioned similarly, and it compels people to reach out across. So we have more chances for collective action and growth in that kind of situation. So I think it's important that we, again, think about intersectionality as something that's not fixed, but is also shape-shifting, right? Which, if it wasn't complicated before, you know, temporality, spatiality, all of those things make it even more complicated just for extra fun and games. But we also, another, of course, complicating factor with migration is the process of being subject to a categorization and as being a certain kind of migrant. And it kind of freeze frames people into these various categories, which have particular discursive constructions, and again, channel people into various places in the social hierarchy, but also have very real implications as to what kinds of resources that they can access. So Anna, again, provided us with a really excellent overview yesterday about those, but I just want to add that when people, that we have to also acknowledge that sort of the international gendered and racialized division of labor informs who comes into the country and how. So, you know, in many parts of the world, Filipino, Indonesian, Nepali, women from Myanmar are you know, allocated to migrant domestic work in countries, many in Asia, but also here in Canada. And we see, of course, that people coming, you know, men from Central America and the Caribbean, and there are all kinds of reasons why, end up being the ones who are migrant agricultural workers here, all temporary workers, whereas we see people coming from other countries, European countries, but also others in South Asia and Asia as being more likely to be allocated to the possibilities of permanent status as professional skilled workers. So we have to recognize that many of the kinds of ways in which intersectionalities are created are happening pre-migration and are part of a global system. So we also saw yesterday, when Anna gave us that overview of the various refugee programs, how certain kinds of programs were, let's face it, color-coded, right? So we see many doors opening and quick response to people from the Ukraine, and I'm part Ukrainian, so I'm not saying that this is somehow bad, but we see what's happened with people trying to come from as refugees from Gaza, and the kinds of barriers that and the kind of limitations, and that has been, I think, historic. So that is another issue that we have to also be watching out for. And I think that the underpinning discourse that helps support some of these differences is a notion that racialized refugees in particular, and again, I'm you know, using broad brush strokes here, but there's still this notion that refugees are the great unwashed, that they are unskilled and uneducated. But you know, when people are fleeing a crisis, those people can be farmers and peasants. They can also be artists and physicians and civil service workers. So we really need to disrupt those kinds of stereotypes that we have. But all of these categories, whether as an economic immigrant or a refugee are all very much infused with these discourses, and those discourses help to also reinforce the kinds of policies and legislation. And they all turn on these notions of deservingness, desirability, and who we think will actually integrate well, supposedly, into Canadian society. But each of these migrant categories also imposes a particular identity, which structures access to social and material resources, prescribes labor market opportunities, educational opportunities, and determines the type and quality of health services and social protection that will be available to them, and the extent of which varies across provinces. So when I worked for many years in Alberta, we would ask for the list of services that migrants of different types could access, and because it could be certain surgical interventions or certain other interventions were not available to them. But the list was always this kind of secret list that nobody knew, they knew existed, but they wouldn't tell you, and it was always changing and stuff. So you can imagine, as researchers, and even as some of the public servants, were never able to actually get a handle on what services people could actually access. So you can imagine it's difficult then for anybody who's just at the level of having a healthcare encounter to be able to know what those services might be. And of course, as we spoke about yesterday, barriers to health services exist even where people have legal rights. And I just wanted to talk briefly about encounters that racialized migrants have talked about in terms of being kind of freezed out from the system, and freezed out by sometimes practitioners. And some of you may have heard in the news this morning about the case of an undocumented worker in Alberta who presented at emergency for our major intercity hospital, and she needed an emergency C-section, and was told that she had to come up with $5,000 up front before she could have the surgical intervention, which is, of course, counter to our policies in the healthcare system. And she was then transferred to another hospital with a different kind of provider, and she was allowed to have her surgery that she needed to save the life of herself and her baby. So, it's something very present. And it's something very urgent that we really think about who gets access and how they get access. So a number of years ago, I did a study of the interactions between nurses and racialized women giving birth in hospitals. And what was really interesting is that in very understaffed maternity wards, meant that nurses really had to focus on economizing their time. So we often heard a lot about how they had to time certain interactions, and the time that they had to be kind of distributed across all these different patients, but also all the different tasks that they had to attend to. So if they had X amount of time, they'd say, okay, well, I'm just surveying the ward and I see certain people are going to require a bit more time for the interactions, and I don't have that time. So right now I'm going to address as many people as I can. So of course they're going to the white presenting women who are in the room. So you can imagine what that meant for the people who were being passed over. So, which was this, frustration. They're reading it as various, personal racism. They're wondering what is wrong with them. They're becoming more agitated and more dissatisfied, not surprisingly. We also found that nurses would say, well, I'm being really culturally competent because I'm going to look around the room and go, this person, fill in the blank ethnicity, they don't shower after childbirth. They don't wash their hair after childbirth. So I'm not going to offer them a chance to go shower because I'm being culturally sensitive and not asking, right? Or I'm not going to teach them how to breastfeed because ethnicity X doesn't do that. Well, of course, I mean, how many of us do exactly what your mother told you to do, right? Raise your hand, like, yeah, right. So, I always remember this one woman who said, my mother told me growing up that I should never wash my hair when I'm menstruating or when I've just had a child because I will get headaches. And then I thought, my dad gets headaches. How does that happen then? And I just thought, I'm going to wash my hair whenever I darn well feel like it, right? And so these women, again, are being, nobody's talking to them. Nobody is addressing their needs. And there's also this presumption that, oh, they're not going to speak English, so I'm not going to be able to explain things to them. This person could have a PhD from Cambridge, right? But they don't know that because they're having to make these really quick decisions. And so while there is, of course, personal racism and stereotyping involved, and it's not only coming from the healthcare and nursing staff that we talk to, but also from patients. So we heard from nurses who said some patients don't want to have a racialized nurse touching them, and so we have to recognize that this goes both ways. But the structural issues also really deeply informed and entrenched those experiences of racist interactions. So the kind of neoliberal healthcare reform that was, happening exacerbates and entrenched those disparities in care that people received. So I just wanted to mention that. Now, a lot of my thinking about all of these issues draws from work that I had done with Somali refugees in Canada back in the 1990s. I know some of you weren't even born then. You could look it up. It really did exist. That was a joke, so you're supposed to laugh, young people. Okay. And in the 90s, Canada received over 70,000 Somali refugees, most of whom were women and children. So Aman, who is a woman in her 70s, said to me, the Canadian people think we have nothing, but we are Somalians and we are rich. I was in my home. Now I'm a refugee. That's the difference. There I was a queen. Here I'm like a chicken. And that's like I'm nothing. So that comment has resonated with me for 25 years. And that vivid description of her pride, her description of lost status, I think is really powerful. So traditionally, Somali gender roles were separate but co-equal, and which really kind of underscores the interdependence that's needed in a nomadic and agro-pastoralist society. So many women I met who were often taking care of not only their own children, but the children of other family members because their parents had been killed during the Civil War or were languishing in other parts of encampments in other parts of the world. They were international business people. They were teachers. They were civil servants. They were farmers. They all had extensive experience managing very complicated households and kin relations. And this really, I think, contradicted this very, Orientalist, Islamophobic stereotype of Somali women as weak, oppressed, and sequestered. And their reception in Canada at the time, so in the 90s, was really fraught. Somalis and the attendant images of Islam were really very negatively portrayed in the Canadian media. There were stories about Somali warlords. There were stories about reputedly, all the violence. Somalia was portrayed as a kind of backward, poverty-stricken land. And there was a lot of moral panic that ensued as these narratives circulated. So there were also stories about so-called Somali welfare queens, women who were just relying on social assistance with lots of children to take care of. But in fact, that last particular stereotype had some seed of reality, and it was because of Canadian immigration policies, right? So the government prolonged, these were all their liminal status. They were all recognized UNHCR, as bona fide refugees. But, you know, when you come from a predominantly oral society and there's a civil war, you're not exactly going to the passport office to go get your passport, right? So there was very little written identification and no photo ID that was, you know, generally not used in Somalia. And so there were questions about who people really were. So they imposed a 5-year, that was later reduced to a 3-year limit, for women to obtain permanent residency status. But as refugees, they were not allowed to invite their family members, which at the time were limited to spouses and children under 19 years of age. It's now 22. And many of these people, you can imagine, were, again, languishing in refugee camps around the world. And so they also couldn't avail themselves of certain health, social, educational programs, settlement services. And so this really left them in a, you know, only being able to generally collect social assistance, something that they were happy to get but not proud to receive. And again, the kinship bonds between especially mothers and children are really central in Somali society. And women, especially as they age, anticipate receiving love, care, respect from their children in consideration of what they have given them. And so the fact that they were separated from other children, from their co-wives' children, their sisters' children, was really very trying and very a great source of stress. So, but when I did my research in Canada, in Toronto, Ottawa, and Edmonton, and when I would visit like the apartment towers along Dixon Road, again, which was always heralded in the papers as, you know, a center of criminal activity and something that was really scary. And yet when I was there, I always felt like I was back in my housing co-op in Edmonton because it was this very strong communal feeling. And I noticed really how older women were warmly greeted. They were deferred to in very tangible ways by young people, regardless of whether they were related. And so it was this very encompassing, you know, community that emerged. They were community gardens and all kinds of things where people felt respected and safe. But a few TT stops away, and the same woman would experience a very abrupt shift in social location. So they were once again read as poor, benighted, oppressed women from a failed state, right? So you could have those same experiences within just a matter of an hour. So again, this illuminates how intersectionality can be configured, transformed, and rematerialized across time and space. For the Somali refugee women I met at the time, the confluence of gender, culture, ethnicity, racialized, socioeconomic and migration status, geography, and age were implicated in how they were situated in the social landscape in 3 different places that they described to me, their homeland, in Canada, and in their diaspora community. So their narratives of home were always embroidered with sort of warm memories of comfort amongst, you know, extended family, of respect that they earned through hard work and investment in caring relationships, and their devotion to Islam. They were members of a majority culture that freed itself from colonial rule. They were a country of poetry and storytellers and of very strong women. So if you ever know the stories about Ira Wailo, please, you know, look them up if you don't, because they're very powerful. Yet in Canadian society in general, there were interacting forces of anti-Black racism, Islamophobia, ageism, and sexism that would continue to haunt them and their families moving forward, generating obstacles to reclaiming prior socioeconomic status and respect from society at large. In their local diasporic communities, however, their intersectional status was reconfigured. Here they were once again a Somali in a Somali environment, a Muslim where Islam was a common denominator. And as older women, they were respected for their contributions to family and to the Somali community at large. Yet the wounds of personal and structural racism, the absence of their kin networks as their members were scattered or lost in conflict, meant they were never really able to recuperate their, you know, original intersectionalities. But we have to also note that there are salutary aspects to being in community that were vital to their well-being. And I think that's a bit of a key for us to be thinking about when we are are thinking about ways moving forward. So, but this embodied impact translated into a variety of stress-related conditions, type 2 diabetes, hypertension among them. They received medication for these conditions, but pills did not reunite them with their children. And so what do we do when we have such complex, really holistic impacts? Humans are messy. And when yesterday the comment was made that we need to meet people where they're at, it becomes even more complicated when people are always changing. But I want to share with you an example of an intervention that I think has particular import for our discussion moving forward. In Edmonton, there is an organization called the Multicultural Health Brokers Cooperative. And the co-op dates back to 1993, when the local health authority wanted to understand some of the issues that were being faced by newcomer women who were having challenges and were dissatisfied actually with some of the experiences they had giving birth in hospital, and also the fact that they were not accessing prenatal health programs. So they enlisted the help of a number of people who were seen as natural leaders in their community, and they had they brought together 16 women to who were not, again, health professionals, but were seen as people who could mobilize. And so they trained them in prenatal health care and set them off to assist women to help in their experiences, their interactions with the healthcare system, navigating the system, getting them familiar with hospitals, et cetera. But when they went to people's homes, they realized, as we were discussing yesterday, that just getting people into the system was not actually going to remedy their situation. They really needed the kind of, they were confronting issues of, the kids needing to get into education. There's intergenerational, tensions. There's, partner violence. There's issues of housing. All of those kinds of settlement issues that we were talking about. And in fact, they started to just take on everything. And so really move beyond this narrow notion of health education to really becoming these intermediaries between the system and these families. And so over time, they decided to become an organization that was independent of the formal healthcare system. And they also wanted to keep it as an organization that was committed to non-hierarchical ways of acting and based on feminist principles. And they formed as a workers' cooperative. That workers' cooperative now includes 100 cultural brokers, and they serve 10,000 individuals per year, 2,300 families from 80 countries, and they work in 30 languages. So this has been an enormous undertaking. They do a lot of work, again, with individual family support, but also in working as co-equals with their formal service providers and policymakers, and as co-equals with the families. So to help them strengthen their own ability to mobilize not only their own households, but also to be part of a larger community and to work in coalition with other organizations and other communities in the Edmonton area. So it's really, I think, an amazing relationship-based program that works across all the various silos, and the fact that they have retained their independence from the formal system and have continued to reflect on and name their own practice, I think has been very powerful. And it's really interesting. There's a little video on that at their website, and you see like youth who had been participating in their programs when they first arrived in Canada who are now working as cultural brokers themselves to help support others. So I think for me, it's a really important and interesting program that might be worth emulating. Okay, in conclusion, some random thoughts. How we can move forward towards more equitable health. I mean, health is a human right that transcends borders and juridical categorizations. If we are really concerned about having a healthy Canadian society, we have to actually focus more on the underuse of health services than the overuse. And again, I think in our discourse, we always hear about immigrants plugging up the emergencies care, et cetera, et cetera. But in reality, in fact, people underuse programs, and there's a whole variety of reasons, of course, why. Importantly, we know a lot about social determinants of health. There's a reason it's called the Ottawa Charter for Health. Like, we kind of invented it. And yet, we still have these really isolated policy and academic silos that prevent us from taking holistic action that we need to improve the health of migrants. So I remember when I did my first independent project as a grad student on issues of immigrant health, my conclusion was that we needed to raise the minimum wage, because people said to me, like, a decent job that is meaningful is health. It's not determining my health, it is health. And so ensuring that people have a living wage can have positive health and, of course, economic impacts. And again, particularly when we look at the ways in which there is, as we talked about yesterday, brain waste, and the ways in which people are overrepresented, particularly, racialized women in the lower echelons of the labor market. We also need to focus on structural analysis. So, there's one thing of thinking about the social determinants of health, but we have to go back even further and say, why? Who are the people who are that don't have access to social determinants of health, and why is it they don't? So we have to think about how, we can adopt a structural analysis that allows us to trace, for instance, how social institutions, schools, hospitals, prisons, regulatory agencies, migration regimes, along with all those isms and forces of oppression, and forces of social exclusion, operate on individual bodies and collections of bodies. And again, I think Ibukun's presentation yesterday really showed how, a well-meaning intervention can have very differential and sometimes deleterious impacts on certain populations. And we need to trace those back and understand why and effect some remediation. We need to look at social violence. So what are the particular harms that those social forces inflict, and on structural vulnerability? So how do all of those forces enhance risk of certain conditions due to one's social location and intersectional status? For health and social care practitioners, tracking these structural issues and unpacking a client's intersectionalities takes time. And I know in this current environment, time for care is severely limited. The model employed, I think, by the Multicultural Health Brokers Co-op, I think, is reflective of holistic relationship-based care that supports individuals, families, and communities in which they are part, while acknowledging and supporting them from an intersectional lens, indeed, where they are at that time. And I think in the long run, increasing social inclusion, social citizenship increases well-being. And I will also put a plug here for us needing radical health economists. I know that we had a presentation from one in my department a couple of weeks ago in my class, and we were so impressed with just how they were able to provide really good, solid economic evidence as to why equity is actually, in the long run, a cost-saving measure, that we all wanted to quit our jobs and become health economists, radical health economists, I must add. Anyways, but I think it's really important in terms of providing the evidence that policymakers will listen to. We also, of course, need to extend to structural issues, the vulnerabilities they produce, and value strengths, knowledge, and expertise. The complexities and the need for systemic and structural change is critical if we want to generate a hopeful, helpful, healthy, and just Canada. As we know, migrants are essential part of our ongoing nation building and our dreams for a more inclusive and just society and world. So I will end it there. Thank you. Sorry.
Thank you so much, Denise, not only for painting the picture, but also showing practical ways in which we can start thinking through solutions. So without further ado, it's my pleasure to invite Diana Gallego for her presentation. Diana is a wonderful friend and collaborator, a Colombian-trained lawyer who has experience in advocacy, human rights, and social justice. In 2002, Diana was forced to flee Colombia with her husband and son, and that experience shaped a new commitment and a sustained commitment that led to her work with immigrants and refugees. She graduated in community work from George Brown College in Toronto and is now a part-time professor in the Center for Community Services at George Brown College. In 2015, Diana joined FCJ Refugee Center and is currently a senior director there. In 2023 fall, she was elected as the president of the Canadian Council for Refugees, where she also serves on the Inland Protection Steering Committee. In that role, Diana advocates for the social and economic integration of refugees and for family reunification. Welcome, Diana.
Thank you. It's a pleasure to be here among all of you. Yesterday, we were talking about the determinants of immigrant health and the intersection of their integration. On the weekend, I observed that on April 7 was the World Health Day. And Professor Anna, our keynote speaker, told us that in Canada, 1 in 4 healthcare workers are immigrants. And those immigrants are the ones that are delivering and improving our health and social services. Then this is very significant because the discourse that we have been hearing these days is against immigrants, refugees that are taking on jobs that are taking and causing the housing crisis. And we know that especially when elections are coming, and I think next year Canada is going to face elections, we are very worried, those that work with refugees and precarious migrants, that this rhetoric and this discourse will prevent advancing for them policies in welcoming them and integrating them. But who we are at FCJ Refugee Center? We are an organization that was founded more than 30 years. This year is going to be 32 years by a couple of former refugees from El Salvador, Loli Rico and our late co-director Francisco Rico Martinez, that they call themselves golden refugees because they were part of the resettled refugees. Means those that arrive in Canada were put in a reception center. They have a social worker assisting them. At the time, Loli was pregnant, then going to doctors, assisting them register children in school. But they start seeing also women, especially women coming from Ethiopia and Eritrea, from war countries, also from El Salvador, Chile, Nicaragua. and they were seeing that these refugees were not resettled refugees. Then they didn't have, they were refugee claimants, asylum seekers, as we know. But in Canada, we call refugee claimants, and there are two kinds of refugee claimants. Those that claim at the port of entry or airport of land border, and most of our land border is with the United States. That means that the journey and the trauma that they, when they arrive in Canada, also has to be with the journey that they took to arrive into Canada. It's different, somebody that escaped with a visa, came, arrived to the airport, and it's different those that have been like recently that we hear people walking, literally walking from, they arrive, for example, from African countries that they can get a visa to Brazil. They arrive to Brazil, literally they walk past Colombia, then they go to the Darien in Panama, and the journey is terrible. The stories that we hear at FCJ are terrible. Then the trauma and the needs that they arrive are more considerable. And unfortunately, these refugee claimants, some of them, they arrive into the country, they don't know that they can claim at the port of entry. Then they come as an inland, means that they will be in Canada for between 2 to 5 months without any support. And imagine somebody that face a lot of trauma, persecution, and will be without any support for all of those months, except that we can connect them with legal aid and wait that a legal representative will send the case to the Immigration and Refugees and Citizenship, IRCC, and that they receive the refugee protection document, and then they can start being supported. Then they saw the need, and they opened a house, especially for women and children, and now we have 5 houses that we host women and children that are not only refugee claimants, but some of them are non-status, and that in Toronto they call them undocumented. Also people that had been trafficked because sexual exploitation or labor exploitation. We serve around between 5,000 to 6,000 people. In 2023, we saw around 6,000 people. And why FCJ, some people will say, wow, how do you see all these high numbers? It's because our center, when somebody comes through our door, our motto is our doors are open for anyone. Then if you go to FCJ on Mondays, we have around 5-6 staff doing intakes. Then anyone can show up to our doors. And in average, on Mondays, we see between 60 to 70 people. And the questions, the legal information that they are seeking is like a rainbow of questions, that from people that just arrived, that from people that have been here for 7, 10, 20 years. Some of them living in limbo. You know, some rejected refugee claimants that are from countries that cannot be removed, that we call them from moratorium countries, that they cannot be removed, but they don't have like a resource to apply and to get pathway to permanent residency. They live in limbo, but also there are others that become precarious because their claim was rejected, the appeals have been rejected, but they go underground. We have many survivors of gender-based violence that in the media we see, recently we saw in the media that the federal government was saying there are many refugees coming from Mexico, and they were labeled as an economic migrants. They were labeled not as a legitimate refugees because they said some of them, the refugee claims were abandoned or the refugee claims were denied. But what the media and the federal government, and especially the Minister of Immigration, Miller, didn't say to the Canadian society is that there is also the category that how you can become a convention refugee or a protected refugee in Canada, put some certain categories of refugees, exclude them from protection. We have many clients from Mexico that they come to our center and said, I have been denied. They believe my claim. They believe what happened to me, that I was persecuted, but because something that is called the internal flight alternative, what means that they can move in another part. For example, in Canada, I live in Toronto, I'm being persecuted by a gang, they believe what happened to me, but they can tell me, oh, you can go and live in Saskatchewan, and nobody's going to persecute you there. Then those numbers were not included in those that were refused. They are legitimate refugee claimants, but they had been told, oh, you can go and live, for example, in Merida, Yucatan. And then some of them, and survivors of domestic violence, they said, I prefer to live underground than go back to my country and face risk of death, even though I was told I will be okay in that part of the country. Then many people are forced to become undocumented, and our doors, as I said, are open to everybody. Then that's why on Mondays we see a lot of people, and even lawyers will tell the clients, I don't have anything else to do for you. Go to FCJ to see what they can do. And our philosophy is, we know your case is very complex. We cannot promise you that we will fix your immigration problem, but we will try together. Then some of the things that we do is to work and to accompany the migrants day by day and to encourage them to work towards an application that may be a solution for them. One of the applications is called the Humanitarian and Compassion Application for people that lost the status of rejected refugee claimant. But it takes time because most of them will not have a work permit. They had to survive. And then they had to take time to do, for example, do volunteer in the community, try to do some trainings, gain experience. Then it's no easy task. At FCJ, we have cases that we work and work with them for around 5 years. Because we do sometimes, we do the appeal, and then we do a pre-removal risk assessment. There are remedies that are for the rejected refugee claimants. Or we have somebody that just arrived into the country, a survivor of intimate partner violence that was promised to be a sponsor, been in the country for 2, 3, 4 years, have Canadian children, and found out that the partner or husband never submitted the application. At that point, they found out, oh, he told me, he took me to an legal representative, and I believe that he sent the application because I provide all the information. Every time I asked, he was, okay, you don't believe me? I did the application. I didn't speak the language. I couldn't talk to the legal representative. And at that point, they found out that they are without status, that they came with a visitor's visa, that they were supposed to receive a work permit. nothing. Then it's sometimes that people, the way that they arrive, Professor Anna yesterday mentioned to us all the immigration pathways that people can come into Canada, the economic, the refugees, the family reunification. And many people even get a scam from the country of origin. We have clients that come into the center and said, I pay $5,000 to a company, and they told me, arrive, and at the airport, we will pick you up and we will give you the work permit. When they arrive, some of them have been picked up and been left, for example, in Finch area, in one of the streets in Toronto. And they are living at Tim Hortons and said, wait for me. I had to go to the office to pick up the work permit, never come back. And somebody working in that Tim Hortons told them, go to FCJ because I think you are another one that was promised a work permit in Canada and nothing. Then they come and said to us, look, I own $5,000 back in my country. I own that money. If I don't pay back, something is going to happen to my family. What can I do? Then I'm calling you and how are you going to tell somebody if you go back, you will not have, you were promised that you were going to earn good money to go back to pay with what? Or sometimes even they said, my mom got a loan and the house says that she will lose the house. Then some of them, they don't have a refugee claim. Then what they are going to do? They are forced to stay underground. And being underground in Canada means that they are going to be afraid to go out, that they are going to be afraid to take a bus, to get into the subway, to go to the doctor, because they don't know if they are going to call Canadian Border Services. Then we see clients that get the mental health deteriorated. But then we have been calling on the government that those pilot programs, that the policies that they have been increasing, bringing foreign temporary workers tied to an employer, means I come here, I work for I'm tied to an employer for 2 years. For example, picking up mushrooms. And many of these workers have been told, you will be earned $23 an hour. And then when they arrive to the farm, they said, you are picking mushrooms, and we will wait what you pick up today. And some of them, they will end earning $8, $10 a day. And when they start saying, okay, sorry, this is not my contract, you need to be quiet or I will send you back home. And some of them already have spent some money, or the family depends that they send money back home. Then they are quiet. Last year, the special United Nations rapporteur said that the temporary foreign workers program in Canada is a breeding for what we call contemporary slavery, like modern slavery. And that's happening in Canada. That's why we are one of the programs at FCJ, sometimes we respond of the needs of our clientele. Because we start with, as you see, these are the programs that we have. We start with the settlement and integration. That was the reception of the women with the children. Then we start seeing unaccompanied minors coming to Canada. Then we have around 140 youth. Some of them refugee claimants, some of them that the father or mother sent them to an uncle to live with them, to provide education, and then they are sent to a shelter and said, okay, you are not welcome more in my house. 6 months, 5 months, go. Then we have a youth network. We developed them the immigration support that I have been telling you that some people already have spent thousands of dollars on legal fees, on things that were promised to them. Some people were told, apply for labor market impact assessment, then you will get a work permit. I have a client that was an engineer from Chile, and he said, Diana, I'm being offered a labor market impact assessment. It's for 2 years contract. They're asking me to pay $9,000. What do you think? I said, where are you going to work? In a Tim Hortons, and he has to drive 3 hours outside of the city. He was paying already $2,800 a month for a salary, minimum salary, and that was all his savings. And when I told him, after those 2 years, you will not have even a pathway for permanent residency. Then he said, why they are offering me this? Then many people spend even $20,000 before they come to us. But others arrive from the airport, directly from the airport, then we support them with a lawyer, we connect them with a clinic, and also we have the anti-trafficking team because the labor exploitation that I already explained, and we have the clinic. And the clinic was founded in 2012 when the Harper government tried to cut for some time the interim federal help for refugees. Then a couple of doctors came to our center and said, we need to provide health care for refugees. But after the interim federal health program was reinstated, then the clinic remains, and we seen an insurance clients. And for example, last year, we have we closed the year with 527 appointments provided by our roster of 4 doctors, and we have also our mental health program with 1 dedicated psychiatric, and we saw 117 people. Then what we are calling is to the government to provide settlement services for refugee claimants, because many settlement agencies that are funding from immigration and refugees and citizenship cannot see inland claims, and they will not see it also non-status people. And non-status people undocumented are the result of the racist and biased immigration policies that the government in Canada have been implementing, excluding many from the pathway to become permanent residency and maintain them temporarily. We have workers coming to Canada and they're temporary foreign workers for 40 years. They get sick, they get old, and they had to go back to their country of origin. They never can come to Canada as a permanent resident. They live here 6 months, 6 months back home. For more, we have clients that come here for 20, 27 years. They got injured, and thank you so much, you can go home. And that temporary is the one that we need to finish. And just to finish, the government, Professor Anna also mentioned that almost 3 years ago, we have a promise to have a regularization program. And to have a regularization program is to provide permanent residency to those that are living in precarious status in Canada, that if they have access to permanent residency, they will have access to all the integration programs and the health care that they deserve. Thank you.
Thank you so much, Diana. And I think you really put a picture to programs and services that are needed from end to support. And I also like the fact that you painted the picture of the trickle-down effects of a flawed immigration and migration pathway. So we've created through the policies blocked pathways so that people cannot go through, and we're refusing to then provide services for them, even though many of these people could be agricultural labor workers that actually ensure that Canadians, people like us, have food on our tables. So we have 2 more speakers before lunch, and I think we can afford to have lunch a little bit later at about 12:15, and we'll still be okay. And now it's my pleasure to introduce to everyone Dr. Vanessa Redditt, who is a family physician at the Crossroads Clinic, which is a specialized primary care clinic for newly arrived refugees to Women's College Hospital. She's also a lecturer at the University of Toronto's Department of Family and Community Medicine and at the Dalalana School of Public Health. Her research, teaching, and practice focuses on the health of refugee newcomers, and the overall aim for her is that we can improve healthcare systems and social supports that are responsive to their needs. Vanessa, welcome.
Thanks very much. I hope that I can lend a little bit of a health provider's lens to some of these discussions, looking at some of the challenges and opportunities in accessing healthcare and system navigation for newcomers, with a particular focus on refugees. I don't have any conflicts of interest to declare. So I wanted to start with a little bit of an overview to the Crossroads Clinic to give an example of a clinic that's focused on newcomer health. We are a primary care clinic here at Women's College that serves newly arrived refugees, the vast majority of whom are refugee claimants. And the clinic was established in 2011 by our medical director, Dr. Meb Rashid, in response to gaps in access to care for refugees, and particularly for refugee claimants who are on interim federal health and who don't have provincial coverage. And as Deanna was just mentioning, this was at a time where there were cuts to refugee healthcare across the board, but those challenges remain for individuals on IFH. So we provide comprehensive primary care, including mental health care, to all ages and genders. And this includes screening and an intake, care for acute conditions, management of chronic illnesses from non-communicable to infectious diseases, pregnancy and well child care, mental health care, and preventative care. And also we try our best to address social needs because we see the importance of that in our patients' lives. Importantly, we have interpreter services so that we can address the diverse language needs of the patients that we see. Our team started very small as one family doctor, a nurse practitioner, and one receptionist. And fortunately, we've been able to grow over time to have an interdisciplinary team that now is comprised of, 2 receptionists, 2 registered nurses, 2 nurse practitioners, the equivalent of 1.6 family doctors, a social worker, and a peer navigator, which I'll be discussing in a moment. And we also have collaborative care with a psychiatrist. We're a transitional clinic where we typically follow patients for the first 2 years that they're in Canada and longer until their refugee claim has been resolved and they have their health card, hoping by that time some of their social and healthcare needs have been more settled, and we try to transition them to a primary care provider in their community. But as you can imagine, given the shortages of primary care providers accepting new patients, this transition is often prolonged and challenging. And it's also the barriers of not having access to interpreter services outside of community health center and academic institutions makes those that transfer of care even more difficult. We really feel, however, that establishing a connection to primary care early on is really important so that a relationship can be built where refugees may feel more comfortable disclosing their physical and mental health concerns so that it can be addressed in a more timely and appropriate manner. And also that there's an existing relationship so that people can connect to care if and when problems arise down the road. Patients are referred to us through refugee shelters that we have long-standing relationships with in the city, and also from newcomer serving organizations such as the Canadian Centre for Victims of Torture. We also receive referrals from refugee lawyers, emergency department, other healthcare providers. But unfortunately, the demand for services far exceeds our capacity. And so really not a week and probably not a day goes by that we're receiving phone calls of people seeking to connect with our clinic that we aren't able to accommodate, and are trying to find other clinics and other resources for them, which breaks our hearts. We would like to be able to open our door, but the capacity just isn't there. And as we see our patients, we witness every day how their lives are affected by adverse social and structural determinants of health and the challenges that they face in accessing services. While people are fleeing from trauma and persecution and often endure perilous journeys to escape, they then face a multitude of post-migratory stressors on arrival in Canada. And these are ones that we've discussed and that those in the audience, I'm sure, are very familiar with, ranging from uncertain immigration status to communication and language barriers, unemployment, financial insecurity, housing instability, separation from family and worry about their ongoing safety, social isolation, discrimination, racism, and the list really goes on. And as we know, these social and structural determinants have a profound impact on health. For example, the grossly inadequate rates of social assistance mean that refugees are stuck in the refugee shelter system or the general shelter system for months and months, or condemned to living in crowded, unsafe housing, grappling with food insecurity. And this has a cascade of negative impacts on both their physical health and mental health, and for that of family members and communities. And so it is critical that we address these social needs to promote their health and well-being. But against this context of a multitude of stressors, we have incredibly complex systems and multiple barriers for accessing these services. So patients are maybe turned away from services that they're actually eligible for because their interim federal health isn't recognized, or because there isn't interpretation available. Patients fall through the cracks, and sometimes there's unnecessary duplications of efforts, which is inefficient for a system, but it also can come at an opportunity cost for individuals who have to take time off of work to attend multiple appointments that could have been consolidated. In our complex systems, both in health and in social services, there are huge gaps in communication and information sharing, long waits, very complex administrative processes and registration processes. I mean, as a Canadian-born, English-speaking, white settler, health professional embedded in the health system, it is challenging for me to navigate our system. Never mind somebody who doesn't speak English, who's new to the country, who doesn't have a social network, who has faced discrimination and racism, who's being turned away, how complicated it is for them to be able to connect to the services that they need. And so, you know, an example of this, and this is one of many, is think about a 39-year-old woman. She's a mother of a 2-year-old. She has diabetes and hypertension, speaks Amharic. She's a refugee claimant, and she's on Ontario Works. We see her in the clinic, provide her with a prescription for medications, but unfortunately, she goes to a pharmacy that doesn't recognize her IFH, and she doesn't receive her medications, or she's faced with a cost where she's choosing between paying for her meds or paying for food. Then, unfortunately, she misses a really important eye appointment because she gets lost on the way to the external ophthalmology clinic. And now she's facing a fee of $150 for that missed appointment. She has difficulties following the lifestyle recommendations to manage her diabetes and hypertension because she simply can't afford the food that she knows she needs. And her mental health is deteriorating as she faces mounting stress, where her landlord has told her suddenly that her rent is jumping by $150, and she's not going to be able to pay that rent and faces eviction. And she can't study English because she has childcare responsibilities. And the list goes on. This is just scratching the surface of the challenges that an individual may face. And so in response to these and other challenges, Crossroads Clinic had long advocated for a peer navigator program to help our patients navigate these challenges. And we were fortunate to receive funding through the Women's College Hospital Foundation, primarily through the Slate Family Foundation and other philanthropic donations, to launch this program in May of 2022. And really the focus of this peer program is about helping patients to connect to the health and social resources that they need, and really providing a wide scope of support. So one individual may need help filling out some online forms or just the name of the food bank that they could access. Another individual may need direct accompaniment to learn how to use the public transit system to get to those resources. And they may need that multiple times until they gain independence to do that on their own. Importantly, there are other patient navigation programs, but we really emphasize the peer aspect of our program, where our peer has lived experience as a newcomer, which can really help to build trust with patients and also can foster a sense of hope and encouragement. Seeing somebody who has walked this journey and has made strides in their own life can bring hope to patients. We also, that language congruence is incredibly important in facilitating access to services. And so in the launch of this program, we identified that our patients who speak Tigrinya and Amharic, of whom we have many patients, really struggle to access services, and that there were fewer services in those languages in the community. And so we started by recruiting an individual, a peer navigator who speaks those languages. Ideally, we would love to have a team of peer navigators, that's our aspiration, who speak a variety of languages that meet our patients' needs, but given the needs of our patients and the gaps in the community, that's where we chose to start. Another feature of the program is that our peer navigator is directly integrated within our interdisciplinary team, and this can really help to facilitate communication and care coordination, where we can do it within a clinical encounter, a warm referral of walking somebody down the hall, introducing them to our peer navigator. We also can have a conversation within the clinic and maybe more efficiently problem solve together. We also use the same electronic medical record so that we're able to communicate in a confidential way to facilitate more timely access to care and coordination. And just as our peer navigator is helping patients to connect with community resources, there's also facilitation of more relationship building and partnerships between our clinic and other community providers, where we can really get a better sense of what services are available and how we can work together to support our patients. And of course, all of this is trauma-informed and empowerment-oriented, with an approach that is helping to build individuals' confidence and capacity so that they can more independently navigate and connect to services in the future. So oh, thank you. And just wanted to highlight that this is our first peer navigator, Semhar Musiel, and she started in May of 2022, and she is absolutely moving mountains for our patients. We are so fortunate to have her on our team and learn so much from her every day. Some of the examples of the peer navigator roles are, as I mentioned, connecting to health and social resources. Maybe that's phoning a service, it's providing an address, it might be helping to fill out forms, or the direct accompaniment, helping people to learn how to use public transit. There's also health system orientation. How do you get a prescription from the pharmacy? How do you get a refill? When should you go to the emergency department, and when should you call the clinic? Also advocacy for patients. Unfortunately, we see that even benefits that people are entitled to, they may be turned away from. And so having somebody to support them in accessing those services can be critical. Also working together with patients to identify what their goals are, whether it's health, employment, education, and then working collaboratively as a team so that we can address those needs. And really importantly, in addition to these practical supports, is the emotional support. And in some of our early evaluation of this, patients really emphasize the importance of being heard, being listened to, having somebody that they trust who they can reach out to. And so that is really a critical part of this program. So now, returning to our patient journey, having a peer navigator in place, she helps this patient to locate a pharmacy in her community that accepts IFH and how she can use her refugee ID to access those medications, and she successfully receives them. She accompanies this patient to the first ophthalmology appointment, and then she's subsequently able to get to those appointments on her own, and has also built confidence in using the public transit system so that she can go to other locations across the city that she needs. She receives assistance in registering for the welcome policy, so she can receive free access to city-based recreation centers, locates recreation centers in her community, finds food banks that are close by to her, and advocates with her Ontario Works caseworker to get a special diet form that the clinician can fill out so that she gets more money each month so that she can better afford some of the food that she needs. And then she astutely recognizes that this rent in Rays is not legal, and helps to connect her with a legal aid clinic so that she can fight this eviction, and also helps to register her child for subsidized daycare so that she can attend English classes, which she helps her to register for, and connects her to early on child development centers. And again, the list goes on. And I will say that before having a peer navigator, we tried our best to address these needs, but within the constraints of clinical appointments, maybe we were only able to give the address to the food bank. And that might not be enough for some patients to actually connect with those services. And we really need to tailor our supports, meeting patients where they are. And some people will need more intensive supports, particularly in the beginning. So this is just one example of a peer navigator program. We were fortunate to hear about the initiatives of the cross-cultural health brokers in Edmonton. There are other initiatives across Canada, and I think that there's an increasing recognition of the importance of integrating community health workers, peer workers into our healthcare teams or partnerships across sectors so that we can really address the broad needs, social and health needs of our patients. Another model of integration is actually the co-location of clinics. So in Toronto, some refugee shelters, including Sojourn House and Christie Refugee Welcome Centre, have clinics that are directly located within these shelters. And as we heard about at FCJ Refugee Centre, located within the social services that they provide. And this can really help to leverage the existing relationships that people may have within the places that they're residing or the social centers that they are already accessing. So building on that trust, and also can help to facilitate collaboration and coordination among healthcare workers and the shelter workers, settlement workers, social workers that they are already connected to, so that we can really work as a broad team to address these diverse needs. So future directions, I think that this is what this series is really about, us thinking about what are different models and policies that can be in place to help integrate health and social services. How can we better facilitate communication across sectors at a policy level where we have different levels of government who don't always talk to one another, where we have health separate from immigration in the jurisdictions that govern, that determine policies? How can we bridge that? Also at organizational levels and at individual levels. Some of the challenges that we face is communicating with a social worker or a settlement worker who is outside of our clinic. We're constrained in the use of email because of the patient privacy considerations, and we need to think about, are there secure platforms that we can use to facilitate that communication? And how can we break down some of those barriers and simplify systems, all with using an intersectional lens and co-designing with newcomers themselves, so that we are really rooting these changes in their lived realities. So I'm going to stop there, and I really look forward to our discussion after lunch. Thank you.
Thank you so much, Vanessa. I love the fact that we have moved to the solutioning phase. Earlier, Denise shared about multicultural health brokers as a model that is working. Diana shared what FCJ Refugee Center is doing, and now we heard about the Peer Navigator program at Crossroads Clinic. So right leading into lunch, I'd like to introduce everyone to Professor Jay Shaw, who is a Tier 2 Canada Research Chair in Responsible Health Innovation. He's an assistant professor in the Department of Physical Therapy at the University of Toronto and he's also appointed to the Institute of Health Policy Management and Evaluation. He currently serves as a research director of artificial intelligence, ethics, and health at University of Toronto, and is an adjunct scientist here at Women's College Hospital. Jay's program of research addresses implementation and ethical implications of innovation in healthcare, where he particularly focuses on innovative models of equity promoting community-based care, digital health technologies, and applications of AI in healthcare. Welcome, Jay.
Okay, well, I'll make up some time. I think we need to get to lunch so we can feed our bodies as well as our minds. So, great to be here. Hello to everyone online, and thank you to Denise and Deanna and Vanessa for those remarks. I think you've done such a great job to illustrate many of the sort of material and lived realities of this topic that we're discussing today, and connecting that up to many of the sort of system issues and challenges and even beyond systems, sort of global context and how they shape the topic we're discussing today. So really have made me think a lot. And the topic of this series of workshops, beyond technology, beyond healthcare. I mean, of course, we've been dwelling in healthcare, in services, in settlement services, in the administration of this system, of this public administrative system of settlement. We've been dwelling within that throughout the last couple of days as well. And so I'll talk a little bit about healthcare services, policy for healthcare services, but I'll try to extend beyond that as well to talk about some ways that technology might matter in this conversation in the big picture. And of course, that's all while acknowledging that it's not the whole story. It's not the whole story by any means. So this is a nod, a look toward technology, while acknowledging that there's a very busy story elsewhere. So there's really sort of two concepts that I wanted to introduce here. The first is this idea of the digital determinants of health, which is a complex kind of multi-dimensional idea. And the second is this idea of digital health equity, which is more oriented toward the role that technologies play in the delivery of services. And in the work that I've done, this is primarily in the delivery of healthcare services. But I would say that this applies toward the delivery of public services more generally. And I know that there's some effort being led across the country right now to contemplate the development of a national network on digital inclusion, part of which is driven from some people within the settlement services sector. So the intent is to outline some directions for policy and governance and lay out some conclusions, but I'll plan to hit the high level, and then we can come back to any points of interest in the discussion. So this idea of the digital determinants of health, I mean, there's been, since the introduction and development of the idea of the social determinants of health, there has been this growing dialogue in thinking about what are the really salient influences on health that we need to call out and name in order to motivate global dialogue about policy. So we've seen work on the political determinants of health and the commercial determinants of health, and that's a strategic move to hold these things up as a point that's worthy of global attention and advocacy. And the same has now been done for the digital determinants of health. The Lancet and Financial Times newspaper in the UK put together a commission that was published in 2021 on the impacts of digital transformations for health. And that represented a really strong focus on this concept, which has now sparked a whole bunch of further work. But this is a busy image, but for those of you interested or familiar with the idea of the social determinants of health, it's probably quite familiar. This is an image of this broader social ecological model, the ways in which our environments, broadly speaking, influence individual health. And these authors have layered on top of this the places where digital technologies impact the influence of these determinants of health. For example, we hear about newcomers to Toronto. How does one find housing? How does one navigate the TTC? How does one find health services? Digital technologies mediate all of these things, unless you're the lucky one who ends up finding somebody speaking your language in the line at Tim Hortons, which is a story we heard about yesterday. So the second and final of these complex images that I'll show, this is a bit of a different way of talking about this. In this piece, they've called out the digital environment as a separate layer of influence, instead of thinking about how it intersects with all of the existing sort of social determinants. So this is really mostly just to say that this is an ongoing dialogue. This work is just emerging now, looking at how digital technologies, because they shape things like global migration, they have a profound impact on health. And naming that and understanding those pathways is an important step toward being able to focus on, sort of coordinate global action to advocate for changes to digital technology industry and the way that technologies are procured and used in healthcare and other services in order to acknowledge the importance of inclusion and social justice. So that's a brief introduction to this idea of the digital determinants of health. And I'll move on now to talk about digital health equity, which is really about how that broader idea plays out in service delivery. As I've sort of said earlier, the focus in my work has been on the delivery of healthcare, but I do think this applies much more broadly. So I'll be talking about, just very briefly, this one project, generating a portable policy framework for digital health equity in Canada. And the idea with this project is to document opportunities for policy change that relate to digital health equity across 4 provinces: Alberta, Saskatchewan, Ontario, and Quebec. And the idea was to look across these 4 jurisdictions in order to generate some insights that might apply more broadly, but also while locating some practical suggestions in these locations as well. And what we've done is a small number of interviews in each jurisdiction, both with policy leaders and leaders of organizations that advocate for structurally marginalized communities. Interview questions have focused on sort of strategies, but also challenges. And we followed an intersectionality-based policy analysis here. We've already heard about that methodology yesterday. And we aim to have some final products upcoming this fall, but have completed our interviews now. And we've ended up with this sort of sample. So six participants in Alberta, 5 in Saskatchewan, 5 in Ontario, 7 in Quebec. So that's just sort of preamble to get to what I really wanted to talk about, which is this sort of this series of relationships that I'll layer in as I kind of walk through this. So what we heard from people through these interviews is that in order for there to be digital health equity, to ensure this ultimate goal, high quality digital healthcare that works for everyone who wants it, there's a set of foundations that need to be put into place. High-speed internet, for example, digital devices that are affordable and available, literacy or readiness, and support. Mechanisms for supporting people who need help to navigate digital technologies. And I've become increasingly interested in connecting with municipal libraries as a means of accomplishing this goal. And of course, we expect librarians to do everything. And they're highly skilled, diversely skilled, and can often do this. But there was, in 2019, the United Nations Special Rapporteur on Extreme Poverty and Human Rights released a report on the digital welfare state and talked about how digital technology is just eroding the sort of delivery of the welfare writ large, not just the financial welfare support. But it just occurs to me that in the absence of these foundations, how is the digital delivery of services meant to be equitable? So, this is probably, again, a familiar story. But as we continued our conversations, we heard a series of policy proposals, how to make progress in this domain. Investments in infrastructure, creating standards that apply, measuring outcomes, actually producing accountability through measurement for organizations that are trying to deliver services digitally. Have device donation or lending programs, literacy support. One suggestion was around sort of investing in equity design expertise for these technologies. But ultimately, what came out as most important, or sort of most central, is this paradigm of policy that is community-specific, community-engaged, and relationship-based. And this idea of doing community-partnered or community-engaged design work for policy was widely regarded as essential here, even though it's not really done. And there are, of course, some success stories. However, it's difficult to make sustainable, to institutionalize in policymaking processes. And this was regarded, the sort of challenges, the reasons for that were described as related to short-term funding cycles, the election cycle. We've already heard from Deanna about that being really important. Financial investment demands. Different people have different ideas about equity. We heard about, in Alberta, the ideas about equity are very different than they are in downtown Toronto. And so this makes it difficult to produce sort of wide, policy is universalizing. It applies to everyone. And so navigating between these different ideas was viewed as a real challenge. Different levels of policy, federal and provincial, how these policies interact is crucial. That's another theme that's come up over the last couple of days. Issues around data, the role of vendors, and trustworthiness of technologies. So, the challenges are many and layered, but ultimately, as we were sorting through this, we came to understand two pieces as really worthy of further pursuit. The first is around this point of policy co-design. How is it that this can be institutionalized? What are best practices? Who's doing this well? How can it be made sustainable? And so, we don't necessarily have answers. Perhaps it's something we can revisit in dialogue, but something that was important. And then secondly, challenges and opportunity around public-private partnerships. And I think that this point, for me, this project is intended to be relevant to domestic policy. But for me, I can't help but step back and think about the global technology industry and these large technology companies, a point that I raised yesterday, and ask about how they interface with states and with the concept of the public good. Now, I mean, sometimes it is those large multinational corporations that governments are relying on in contracts for local services, and sometimes it's smaller companies. But ultimately, getting right the governance between vendors, without whom there would be no technology industry, and public services is an essential step forward. So, just final sort of few points here, my last slide. The challenges of digital health policy are the challenges of health and social policy more generally. For example, things like co-design. Digital health policy is only effective when thinking beyond digital health, something that's become, very clear to me as I've listened over the last couple of days. And finally, technology policy, in a general sense, is also health policy. In the way that jobs is health, jobs are health. Technology, in many ways is as well. So I'll conclude there, and I'll look forward to our discussion afterward.
Thank you so much, Jay. A nice lead up into lunch, which will allow us eat, percolate with questions, and then come back for the Q&A session with all the panelists, which will be facilitated by Nancy. So quick one, lunch is outside. If you had dietary restrictions, just check for boxes with the labels that will tell you which is yours. There are no names on the specially packed boxes. While we are breaking for lunch, please feel free to go visit Brittany, take a sticky, write some of your thoughts from your notes, high-level thoughts that she can then incorporate into the graphic recording. We'll also be sharing the graphic recording on the screen just so that people can take it in and share their thoughts. Those who are online, please feel free to also contribute and share your thoughts about the recording in the chat. So we'll see you back at 1 p.m. sharp. Enjoy your lunch.
Stumbling let myself down to the bottom. There is no place to hide and no one can call me. My name is so dirty, call me dirty girl. You made me a symbol, so I'm on my own. Falling apart, no stopping to lose. I'm clumsy and not, you call me a loser. La 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 la. La 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 la. La 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 la. I swear you can call me a loser. La 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 la. La 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 la. La 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 la. I swear you can call me a loser. I swear you can call me a loser. La 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 la. La 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 la. La 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 la. I swear you can call me a loser. My name is so dirty, call me dirty girl. You made me a symbol, so I'm on my own. Falling apart, no stopping to lose. I'm clumsy and not, they call me a loser. La 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 la. La 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 la. La 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 la. I swear you can call me a loser. La 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 la. La 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 la. La 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 la. I swear you can call me a loser. I let myself down to the bottom. There is no place to hide and no one can call me. La 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 la. La 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 la. La 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 la. I swear you can call me a loser.
Yeah, it is. It's a talk show. All right, everyone, welcome back from lunch, and thank you so much for still staying in conversation with us. So as promised, we're going to start quickly with a moderated panel discussion, 20, 30 minutes, maybe longer, hopefully not. And then after that, we will have trainee and scholars presentations. So over to you, Nancy.
Okay, great. Thanks for coming back, everyone, and hope you've had some lunch. And for those of you online, welcome back. And what we thought we'd do is maybe just do a quick recap of some of the learnings from this morning, and then maybe see if you had some questions for follow-up. And just wanted to thank again our distinguished panelists. That was an amazing 4 presentations, very inspiring, despite the topic of our conversation. So just to bring everybody back, we started with Dr. Spitzer, who really led us into grounding in understanding around intersectionality and looking at structural inquiry. Particularly, I wanted to highlight Denise's conversation around newcomers being freeze-framed and categorized, and how those categories shape the trajectory of access to care, and also maybe even reshaping identities. The other thing that I wanted to highlight around Denise's presentation is around the Multicultural Health Broker Co-op program, which was also something that was inspiring to hear about, and what's working for people that sort of changes the discourse and changes maybe the trajectory of well-being and care as people are being freeze-framed. Following that, we had an excellent presentation by Diana, who talked to us about the Refugee Center and refugee claimants and asylum seekers, and also brought attention to the legal status and that where inequities happen there in the legal system. However, even with speaking about that and hearing about those stories, we also learned that through legal aid and through the establishment of the center, that you're also able to provide housing and support for undocumented workers, and particularly women and children. So I found that also very inspiring, despite all the oppression, if you will, that particularly migrant workers and undocumented people continue to experience. Then we were engaging with Dr. Vanessa Redditt. Did I say that right? Oh, good, thanks. And walking through the story of what it's like to actually access a primary care clinic at the Crossroads Center, and talking about comprehensivity of care, but also drawing attention to the Peer Navigator program and how that program has really addressed some of the challenges to bridge the gaps around cultural brokering, language, and also navigating the healthcare system, and drawing attention to how a story and a trajectory can actually be changed yet again. Finally, we concluded, or started, if you will, another opening dialogue with Dr. Jay Shaw, talking to us about policy, technology, and healthcare, and actually drawing attention to the digital determinants of health, and talking to us about how digital technology, starting from shaping global migration to what it might look like intersecting with all social systems and health services, and how digital health and technology We really need to think about how it's integrated throughout and then putting an equity focus on that. So to me, those were the key takeaways and the summary of today's or this morning's discussion. And I was speaking with Ubicon earlier talking about that, what this kind of reframing of these structures is really more of a bringing sort of that appreciative inquiry lens to the work that our distinguished panelists have presented, the work that actually is working. And that work always comes back to community and community-based services, how people get together, how these organizations actually create systemic change. So that was just a brief summary, and I wonder if our panelists want to have any comments to that, or if we have any questions from the audience. Or online. Go ahead.
I have a question, and I think Nancy also touched on the fact that we're talking about this over lunch. And I'm now thinking of like solutions, and maybe I'm getting ahead of myself. But we were seeing, the different options you presented and the examples while grounding, the narrative around equity and social justice and intersectionality. Can you talk a bit more about how would you say it? The fragmentation between, community organization, CHCs that are driving this work forward, and policy, right? It's almost like it's worlds apart. Immigration policy is example why we have gotten here in the first place. And then your organizations, through policy research and action, trying to solve for that. How do we bridge those gaps so that our action is not solving for problems that could have been avoided in the first place? Does that make sense? It's like, how do we stop this reinforcing cycle of policies initiated, the effects of that policy lead to structural injustice, and then organizations, grassroots organizations, community advocates have to come together to solve for that when we could be expending our energies elsewhere. So I guess I'm now asking about the integration between policy and action. And anybody can take the question.
Maybe I'll get us started. I mean, I think I'm kind of sort of thinking of a way into addressing your question, Ibukun. I mean, I think in some ways policy, like it sets this. It's a function of legacies that are inherited over time, and it sets the structures against which people like Deanna and the work that her team does and Vanessa are constantly working against. I think that if you take a long run, like a long-term perspective on what policy is, then you can see that it's something that tends to evolve over time, in fits and bursts, sort of punctuated by these moments of change, and it produces like the structural background that needs to be constantly navigated, right, by people. So the idea of like bridging between policy and practice, I'm not sure that's like the right metaphor in relation to this particular topic area, but perhaps rather about engaging in practice on the ground in a deeply disadvantaged context where policy produces structural barriers, structural disadvantage, and that there's the work of helping people to soften the blows of this structural disadvantage produced by policy. And at the same time, it's a different kind of work to go and, knock on the doors at in Ottawa or at Queen's Park here in Toronto and try to advocate and rally support and make efforts toward change. I see these as two very different domains of practice. Where I guess just a final thought, like any bridging might be about bringing the learnings and the lived experiences of people who are newcomers that we've heard about over the past 2 days, and the people trying to do the settlement work to support people in settling, bring those insights to bear to the halls of policy, to the ivory towers where people are making the decisions. So those would be my sort of reflections on your comment.
I will add that it's important, like the work of getting together researchers with frontline workers. Because sometimes politicians, those that make the policies, they love to have data, numbers. When we always said is we are just no numbers. We are persons, we have families, and your policies affect us. Then don't see us just as numbers, because, for example, for family reunification, immigration said, oh, this year we are going to reunify 25,000 families with the protected persons in Canada. Then we said it's just no 25,000. We have right now around 90,000 people protected that claim refugee protection, got accepted, waiting to be reunified. And then they are going to have to wait 4 or 5 years. Then when we bring researchers with frontline workers and with people with lived experience, we can present them the alternative, how they can fix those numbers and create welcoming policies, no barriers. Then I think it's important that work, because sometimes we see research based on just them working in the academia, but not coming to the ground and talking to the people and bringing real experiences. I think those can influence change. Change takes time, but we see changes. Sometimes little by little, but I think we need to have the presence always and the constant battle, because again, we are not just numbers. The policies are affecting many, many lives.
I think this is on. So thank you, colleagues, I think, for opening up these remarks. I have sort of 2 trains of thought. One is that, drawing from what Diana just said, I often, as a community-based researcher, say that I'm a munitions maker. So my job is to work with communities, to build and create rigorous research that is grounded in lived experience, that is well documented, and to be able to convey that in ways that we all have access to use and leverage in whatever positions we are. So, to carry on that notion, we make bullets that can be fired from all directions. And the only time that I feel that I've had any impact on policies or programs is when it has been a collective effort from, as one of my colleagues called it, the Parliament of the Streets, people from communities pressuring and lobbying and making demands. That's also using sometimes the evidence that we in academia produce with them, but also, of course, their own lived experiences. And we have that, again, complemented by whatever efforts we're able to make in trying to influence policymakers, whose doors may be open occasionally to academics that sometimes are colleagues in community organizations, or just as people in society are not able to access. So I think we have to, even though academia really prioritizes this kind of individual researcher as hero role, that we really need to, in academia, just reject that kind of discourse and be able to create work collectively that can actually have some impact. And you're right, it takes time. So that, to me, I think is one thing that we can do. I also just wanted to think about ways that we can look at kind of the, I guess, meso-level policies and try to push for change. So for instance, in our immigration policies, we have a point system that really prioritizes certain kinds of skills in ways that are highly gendered. So when I was working for many years with people who came under the live-in caregiver program, now the caregiver program, 63% were university educated at the time compared to 36% of people who came as economic migrants. And we know that caregiving is actually not babysitting. It's extremely complex. And people who were hiring caregivers were not getting babysitters. They're getting people who are nurses, who are teachers, who have all kinds of other kinds of skills that are being drawn upon in order to care for children, the elderly, and persons with disabilities in private homes. And yet they are classified as, classification C, which is semi-skilled, and they were, and that follows them throughout their migratory journey. So when people would become caregivers and then you're trying to, at the time you couldn't bring your families with you and you had to, it was a two-step process, and they would be compelled to get whatever jobs they could get afterwards. And they often ended up as personal care attendants or registered nursing assistants, even though they could have been physicians or registered nurses in their home countries. But if you are a single woman and you want to bring your family with you, as we noted, our ideas of family include just spouse and children. So a person who wants to bring maybe their parents to join them, because as we know, social support is really critical to people's health and well-being, you have to meet an income threshold. And if you are doing gendered, racialized labor, you're not going to meet that income threshold. So I think there are opportunities for us to make kind of cases for a revisiting and a revamping of these kinds of really discriminatory processes that continue to place people in very precarious positions. So I think that's another area of action that we can take.
And maybe just a final comment to build on the excellent insights that have been shared is thinking about ways that we can also condense that gap between research and implementation and policy change, being able to really leverage and build upon emerging best practices, often that are coming from small grassroots organizations. They know their communities well, they have incredible innovation and answers, and building on that, funding those organizations, and really disseminating that deeper into the community where solutions already exist, and we don't need to necessarily be recreating the wheel, but building on the amazing work and emerging evidence that already exists.
That's great. I think we have our we have some method forward, and it sounds like the collective theme here is that the drivers of change and the drivers of system change all come down to the things we were talking about before, the collaboration, the integration that's required across these systems. Were there any other questions or comments from people in the audience or online? Okay, go ahead.
Yeah, I can read a comment that came from online. It wasn't a question, but from someone who's coming from an immigrant to Canada in 2018 and navigating the whole process and adjustment of settling into the community. They also acknowledge, the issues and the constraints that they have to overcome. And so they themselves feel more inclined to support their own community. But what they're seeing with working with these kind of communities is that though clients who are coming in as newcomers who have a work permit, but they're not able to get access to OHIP, and they don't have a permanent job contract, and they're working to pay their taxes, but they're not eligible for OHIP. And so this person's coming from the side that we need to start advocating for adjustment on policies and eligibility criteria with the government and on a provincial level to adjust this to be able to provide more care to people, because the eligibility for being allowed for a community health center registration or just as a visitor or temporary resident in itself is null. And so they also commented on the idea that Dr. Vanessa Redditt was sharing about the constraints on taking on more people. And they have the motto of saying no to no one, but we need to go above and beyond this. And so how can we use the technology that we have at the moment to utilize the new generation of assets that we have to be able to combine these practices that we currently have and enable them to be more accessible and tackle the barriers that we have at the moment.
Anyone would like to comment? Vanessa or Jay or?
Yeah, I would say, thank you for sharing those reflections and sort of, arising from your own experience. I think that's a really important input into this conversation. If I caught that bit at the end accurately, I think the question was about how can we take advantage of technology and other tools to essentially serve more people. And I guess I would say I would put a caution back to that sort of suggestion that the finding real life examples of where technology has successfully, in a more or less error-free way, enabled the delivery of services to more people. Those examples are few and far between, and it's really hard to do. One of the key things that we've heard about again and again over the past couple of days is how complex, multi-sided, and the demand for coordination that characterizes the kind of work and the access to services that we've heard about recently. And if you did a zoom in on this system, you would see technology everywhere. There's digital record storage. There's video calls and telephone calls. In healthcare, there are coordination systems, and each of these plays a role in a certain tiny corner of this complex network of organizations. But the idea that, for example, shifting to phone calls or Zoom calls as a way to deliver services will allow us to serve more people is, I think, not the most promising avenue to pursue. The idea that technologies can save time, for example, by summarizing clinical notes or by generating advice, artificial intelligence generating advice for people. Although these are ideas worth pursuing and are being trialed in many parts of the system, it's important to take due caution, because these are life and death decisions, right? That's another key thing that we've heard about over the past couple of days. So, I channel thinking from a community organizer and technology commentator, Bianca Wiley, who says, when it comes to things like AI, we generally need to slow down, as opposed to hurrying up, and make sure that we're studying the impacts of these kinds of technologies properly. So that would be my thought.
So Jay, thank you for that, very critical comment, which sort of like pauses even me in my head to slow down. And now I'm asking, well, then what can technology do? Like, what should we use it for, apart from mobile phones? So, like, do you see any promising solutions?
Yeah, I guess, I have this role as like a research director about technology, AI, ethics, and health, as I spend so much of my time naysaying about technology. I think sort of the point and the trend that I'm trying to counteract is techno-solutionism as a dominant idea, you know, which is an idea that essentially, you know, many would say that it characterizes the mentality of people who have founded big technology companies, you know, located in Silicon Valley, and that it's this idea that we can code our way to the solution to any problem. Technology can solve any problem, but technology cannot solve the housing crisis. You know, technology cannot solve racist allocation of resources about, you know, which people in crisis get to come to Canada and which don't. So I mean, I would say that there are things that technology can do. Technology has become very accurate in predicting demand for resources, for example, in staffing levels in hospitals. It has been applied and used in effective ways around things like image recognition for diagnostics, you know, in hospital systems. I bring these examples up only to say, of course, there are low-hanging fruit where a person is able to check for mistakes, or the outputs of these technologies are informing a human decision about things like where to put resources, where the risks are low and the technologies have proven to be quite effective. You know, and of course, things like an integrated digital record system would be incredible for the healthcare system more broadly speaking. But in a world, you know, this province in Ontario, I think we have 27 active electronic health records in primary healthcare in Ontario. Somebody can correct me if my number's wrong, but it's more than 20, I believe. And I mean, how to navigate coordination between all of these, it's an immense challenge. So would having a single digital record help in the administration of public services? Yes, absolutely. So I do think that there are many instances where technology can be a real benefit. But I think we need to work together to kind of cut through the hype and not focus on technology at the expense of the real advocacy and policy solutions that you know, we've heard raised over the last couple of days.
Oh, great. I think we're almost out of time, but I just wanted to give Vanessa the opportunity because, nope, she doesn't want to respond. Okay, well, it was just in comment to the caller that was, I think, also talking about the discrepancy interprovincially and getting health insurance. And I was wondering if there were any comments about that, because I think it was a policy-related question around why people, you know, again, talking about access to healthcare.
I can speak to that briefly, and there were so many important points raised in this comment, but yeah, we have seen that there are discrepancies in the wait time to getting provincial health insurance depending on which province you're in. And we also have seen policy changes. So in Ontario, previously there was a 3-month wait to get provincial health insurance if you were coming as a permanent resident. And that often put people in very precarious situations, and that their health deteriorated during that time before they got their health insurance. During COVID, there were changes, and then individuals would receive health insurance upon arrival. There was also a temporary period where anyone, regardless of their immigration status, was able to access healthcare services. Unfortunately, in March of 2023, that access to healthcare services for anyone was repealed, but the elimination of the 3-month wait has been, to this time, sustained. There is variability in different provinces around that wait time, but we see how when there is some political will, we can make these changes that we know are needed. And just a few other comments to respond to the online question. Interpretation services. We don't, in the province of Ontario, we don't have access to interpretation services broadly in our healthcare system or in our social service system, and that's a huge gap which has real repercussions and potential damage, even leading to serious medical errors and death for patients when they don't have access to those services. And that is a policy change. We know it's needed. We don't need to build more evidence. We actually need to fund this critical service. Just as one example. Also, in terms of funding interprofessional, interdisciplinary healthcare teams, we see how having a walk-in doctor or a fee-for-service-based primary care clinic really is not going to meet the complex needs of newcomers. There needs to be integration of social workers, of community health workers, to really address the broad range of needs. And again, that can be a policy decision about how funds are allocated, and ensuring that the funding of these interdisciplinary teams are in the places where people who need these services are living.
That's awesome. That's a great wrap up. We know what works. Let's implement. So thank you, everybody, and thank you to our distinguished panelists. Awesome presentations and conversations. Thanks so much.
And thank you so much to you too, Nancy, for the great facilitation of the conversation. And so now we move to the next segment of the program of the day. I'm going to be inviting Tasneem Khan to the podium to speak to us on her topic from her work on the mental health of immigrants in Canada, neighborhood deprivation, and sense of belonging to community as determinants. Tasneem is a PhD candidate at the University of Waterloo, where she is examining the social and economic risks for the mental health of immigrants and immigrant women in Canada using National Statistics Canada data. Her interest in mental health equity developed from migrating to Canada at a young age and studying psychology and neuroscience during her honors Bachelor of Science at the University of Toronto. Tasneem, you're welcome.
Thanks, Ibikun. So hi, everyone. First of all, thank you so much for such a great panel and tackling all these complex topics and issues. So I will be speaking about the mental health of immigrants in Canada, mainly from a survey research perspective, and I'll be then going into presenting some results from one of my PhD studies and parts of it which looked at the neighborhood and community context factors as determinants of immigrant mental health. So to give you an overview of the presentation, I'll give you an introduction to myself and then a little bit of an overview of the survey research literature that's present on immigrant mental health in Canada. And then I will briefly discuss the gaps that are present in this area and how my PhD is filling them. And as I mentioned, I'll go into one of my PhD studies, and then I'll wrap up the talk by discussing a little bit about what we can do with this information for programs, as well as the takeaways for future research. Okay, so as Ibikun mentioned, I'm a PhD candidate at the University of Waterloo, and my general focus is on the social and economic predictors of mental health for vulnerable or at-risk populations. And this includes research on immigrants as well as immigrant women, immigrant mothers in particular, as well as South Asians in Canada, and some research on Indigenous peoples in Canada as well. And I've been mostly using Statistics Canada to conduct my research. And then just to kind of clarify here, by vulnerable, here I'm not referring to learned helplessness or passivity on part of the individuals or the subgroups within our population. Rather, it's referring to the conditions that are rendering individuals and some subgroups in the Canadian population and all across the globe to be more susceptible to risks for mental illness and other illnesses as well. And so this definition by Schroeder and Geffen summarizes this concept very well, and that is that to be vulnerable means to face a significant probability of incurring an identifiable harm while lacking the means to protect oneself. And in today's talk, I'm focusing on the mental health of immigrants in Canada. So To give you a bit of background on the numbers, Canada is one of the top host countries for immigration, and we are accepting around 400,000 migrants annually, and that's mostly for the economic program. And this number is expected to increase to about 500,000 by 2025. And we've had lots of discussion around the importance of immigration. So, you know, it's a very important area of consideration because the successful integration of migrants is a key topic. And in relation to mental health, the migration process itself can be very stressful due to relocation, and especially during the acculturation phase in which migrants are introduced to a new society. It can impact their mental health. And so in that sense, the support systems present during the integration phase are very important in assisting migrants and helping ease the process. So with regards to the research in Canada in relation to survey research, most of it's focused on the healthy immigrant effect. And the healthy immigrant effect basically relates to or means that when migrants first arrive, on average at the population level, what we see is that they have better mental health and physical health than native-born Canadians. But then there's also some focus on length of time effects. So there's literature on the effect of long-term stay in Canada at the population level, and what we see is about the 10-year mark, there's a decline, and there's a deterioration both in the physical and mental health of migrants, and it becomes in par with the Canadian-born population. So this is it's somewhat of an old example, but it still stands obviously true that if we look at the graph, by the 10-year mark, the prevalence of depression for migrants becomes almost similar to the Canadian-born population. And then from my understanding of the literature, a lot of it's largely focused on individual level factors. So age at immigration, ethnicity, as well as cultural background. And all of these are very important factors. But then there has to be more attention to contextual factors, as the determinants of mental health can obviously be individual as well as those related to our living environments. And there has been limited investigation of contextual factors such as neighborhood factors, including both social and economic factors, and such as collective efficacy in the community in relation to the mental health of immigrants. So my PhD is filling this gap in the literature, and a lot of it's focused on socioeconomic and gender-related factors and contextual factors in their relationship with the mental health of immigrants. And social and economic factors in the living context can interact and intersect with the immigration status, and then come together and have a compounding effect on the mental health outcomes, and that's why I've made it my focus. And so in the first study for my PhD, I used survey data to examine household, neighborhood, and community-related predictors of immigrant mental health. And today I'm just focusing on neighborhood deprivation and sense of belonging to local community factors. And this study was jointly conducted with my PhD advisor, Martin Cook, at the University of Waterloo. So using an ecological framework, the two of the questions we asked were, are immigrants more exposed to factors at the neighborhood and community level that are potentially unfavorable to mental health? And second, how are these contextual factors associated with the mental health of immigrants while controlling for individual level factors? For the analysis, we used the Canadian Community Health Survey and the Canadian Index of Multiple Deprivation. And the total sample size, it's a national data set, the Canadian Community Health Survey, and the total sample size was 120,000 people with about 13,000 immigrants. And the individual level factors were taken from the Canadian Community Health Survey, as well as the mental health outcomes. And we had two mental health outcomes we were interested in. One was self-rated mental health, and the other one was self-reported diagnosis of a mood disorder. The Canadian Index of Multiple Deprivation is developed by Statistics Canada as well. However, it is mainly focused or based in the work of Flora Matheson, who generated the Ontario Marginalization Index, and it's an area-based index of the population, and it measures deprivation in the neighborhood using 4 key dimensions. And these dimensions are residential instability, economic dependency, situational vulnerability, as well as ethnocultural composition. Here, I'm just going to give you like a brief kind of an understanding of what these measures are. So residential instability basically refers to the tendency of the fluctuation in the neighborhood, taking into account both housing and family characteristics. Economic dependency relates to the proportion or the number of people in a neighborhood that are relying on sources of income other than their own employment income, for instance. And ethnocultural composition, as defined in the index, refers to the community makeup of the neighborhood. So the proportion of immigrants and the proportion of people who could not speak an official language. And lastly, situational vulnerability refers to the socio-demographic conditions, such as housing and the type of dwellings and conditions in the neighborhood. And then the dissemination area is the way neighborhood is defined in the index. So it's the smallest geographic unit in the census, and it refers to a block of an area with about 400 to 700 people. So for the first objective, we looked at percentages of immigrants across different levels of neighborhood deprivation measures, as well as sense of belonging to local community. And we also compared these percentages for immigrants and non-immigrants. For our second objective, we used logistic regression models to look at contextual factors and how they relate to mental health while controlling for individual factors as well as length of time in Canada. So what did we find? We found, so if we look at both of these graphs, and if you look at Q5, what we found was that with respect to neighborhood level exposures, compared to Canadian-born individuals, immigrants were more likely to be exposed to high levels of residential instability, and also had more proportions of living in areas with higher ethnocultural composition, and this is what we would expect. So Q5 is the highest level of deprivation here, and so for these two, immigrants were higher in proportions, but not as what we would have expected. We didn't find that immigrants were in high levels of economic dependency and situational vulnerability neighborhoods. So it was contrary to that, and there were more proportions of immigrants in the quintiles with low economic dependency as well as low situational vulnerability. The results of the sense of belonging to local community they're somewhat important, I would say, or different. So if we look at the very strong sense of belonging to local community, there's a significant difference there. Immigrants are reporting more levels of very strong sense of belonging to local community, but then the somewhat strong sense of belonging to community reports are pretty similar for both populations. These are the results of the logistic regression models, and these are for immigrants only. Each of So for each of the deprivation measures and sense of belonging to community, each is a separate model. And for each one, it's the relationship between each factor and mental health. And it's controlling for age, occupation, provincial residence, as well as length of time in Canada. And so the two most important key takeaways from this would be very weak sense of belonging to local community was related to poor mental health outcomes. So the odds were higher for immigrants reporting very weak sense of belonging to local community for poor mental health. And the other important one was, it is situational, sorry, I don't want to say this wrong. It's hard to see the graph. So sense of belonging to community. Okay. The other one was, yeah, it's situational vulnerability. So if we looked at the situational vulnerability results, the odds were significantly higher for those living in situational vulnerability neighborhoods to report more mental health, poor mental health. We didn't see an association between residential instability and economic dependency with poor mental health outcomes. So the lower two graphs, if you look at them, there's the reference, the key one is the reference, so there's not much difference between the reference and the other categories. Okay, so in conclusion, we did find that immigrants were different from non-immigrants in their exposure to neighborhood deprivation factors, as well as their reports of sense of belonging to local community. And we did see sense of belonging to community to be an important aspect of mental health, and it's very much related to mental health. And we didn't obviously see anything for residential instability and economic dependence. And lastly, so just one note here, you can take it both ways. Sense of belonging to local community, if you report lower, you'll have worse mental health, but it could also be protective for your mental health, right? If you're reporting higher levels of sense of belonging to local community, that's great and it's good. Okay. All right, so what are some of the implications? Some of the things we can think about are those living in low economic areas with low economic prosperity and living in ethnic silos are kind of more at risk for mental health, and programs to foster a sense of belonging to community could also promote mental health among immigrants. And some things to think about for future research would be like, what are the underlying mechanisms that promote the sense of belonging to local community? And for instance, is it the social networks? Is it the feelings of trust? What are the mechanisms? Also, how might these relationships and exposures differ for different groups of migrants? Newcomers, refugees, and as well different demographic groups as well. So for people from different ethnic backgrounds, as well as by gender. So this is feeding into my next PhD study as well. And for that, I'm focusing on contextual aspects of the mental health of immigrant mothers. And that's also using Statistics Canada data. And lastly, I just want to acknowledge the Statistics Canada Data Center in Waterloo for the data, and all of you for listening to my talk. Thank you.
Thank you so much, Tasneem. Like, such an impressive and relevant piece of research. Thanks. So, questions. I think we have time for at least 2 questions. I have some, but it would be nice to hear from people in the audience. Okay. I was very curious. Okay. I'm trying to see, like, which question should I prioritize? For the community health survey, do you recall how community was phrased within the questions? Because I was thinking about how, in responding to that survey, you could think of community as the ethnocultural immediate space in which you live, which would likely offer a sense of protection and stability and safety versus the larger societal community. I'm just curious about that because that may explain why some of the results, for me, there was some discordance there.
Okay, so just to clarify, the sense of belonging to local community, that was a question on the Canadian Community Health Survey. The other measures were from the marginalization index, so they're both not related to each other. One is neighborhood factors, or the way they define it is neighborhood factors. The other is community. So that's one thing. The other is the question asked, what is your sense of belonging to local community? That's it, that's the word. So I would imagine it's referring to one's immediate environment. Yes, yeah.
Thank you.
Yeah, thank you very much for this really eloquent and well put together presentation. Bravo. It's raising lots of questions and also resonances with things that, as mentioned before, that with the Somali women that I did work with, that having that sort of co-ethnic community around them was like super supportive. But I've also done work where we found that people who were shared maybe status as newcomers, but were actually from disparate countries, and some were Canadian born, but all sort of very similar sort of economic backgrounds, that there was a lot of social support given across those what we would sometimes see as barriers. So sometimes it was easier to ask somebody who wasn't from your own ethnocultural community for, can you look after my kids while I go to a medical appointment, than it was from somebody who was from your own community, because you might not be able to reciprocate, right? So I just wondered whether I guess, again, about the constitution and of community, and if you don't have that information now, if that might be something you might want to look into in your future work, is really thinking about what community means, who's part of that community, and what that means for kind of different ways of bridging social support and social capital.
Thank you. Those are very good points. I guess one thing that I can kind of connect it to is the ethno-cultural composition measure. And when I was studying that, I would have thought it's similar to local community because ethnic density is supposed to be protective, right? But then we didn't see that to be protective for mental health. And it's also part of the deprivation index, which kind of throws you off because why? But then at the same time, when we look at the measures that are used in it, it includes the proportion of people who cannot speak an official language. So it speaks to the marginalization aspect of it, right? Not being able to connect to the broader Canadian context and maybe being siloed in. So good points to think about further. Yes, thank you.
Thank you so much, Tasneem. Okay. So thank you everyone for being so supportive, and welcome back. We had a brief medical incident. It's all been taken care of. So just a quick recap on what you can expect. Dialogue 2, day 1 is going to be Monday, 13th of May, hybrid as well. For those who are able to join in person, please join us again in this auditorium, Women's College Hospital, on the 13th. Programming will start at 10 a.m., although you can come early at 9:30 for check-in and light networking. Our keynote for the day is Professor Kevin Potty, who is a researcher and a distinguished professor in digital transformation and health equity. We'll have a moderated Q&A panel after his talk. Then we'll break for lunch and networking, followed by panel presentation similar to what we had today. On day 2 of dialogues, that is going to be exclusively in person because it's going to be a co-design workshop. There we're going to be supported with facilitation from Health Common Solution, where we're going to take all the learnings and reflections from our conversations that have started yesterday and come together to think through what would an action framework and intersectionality informed toolkit to promote and support equitable and integrated support for newcomers to Canada look like. And afterwards, we'll have a visioning exercise, and then we'll wrap up. So with that being said, I look forward to seeing you all in May. Thank you so much to our funders, to those who've made the time of their presence and their wisdom and all that they could give to be here, our funders and supporters. Wish you well, enjoy the rest of your afternoon, and travel home safely for those who've come from out of town. Thank you.